Hi, my name is Jennifer Gurske-dePerio, and I'm an orthopedic surgeon with UBMD Orthopedics and Sports Medicine, and it's my privilege to go over the foot and ankle exam with you today. We'll start with gait assessment, which is one of the first things you'll see when the patient walks into the office. So Sammy, would you mind standing up for me? So when patients present to you in the office, one of the things you'll notice is if they're carrying a cane, a walker, crutches, are they in a boot, are they in a brace? That's one of the first things you want to note. You want to ask the patient to walk. So we'll have you walk. We don't have a ton of room in here. But as we're watching Sammy walk, she has a non-antalgic gait pattern. That means she's not limping. Some folks will present really favoring one leg, so you want to take notice as to what leg they're favoring. You'll also want to look at the whole body. So if they are lurching to one side, look for a Trendelenburg gait. That would refer to their hip because there's other joints associated with the leg, not just the foot and ankle. You'll look for any steppage gait. That would be if somebody had a foot drop. So you're looking for anything that looks abnormal, or if it's normal, take note that is a normal gait pattern. So assisted devices, antalgic, non-antalgic, any foot drop, any lurching to one side or the other. I'll have Sammy face this direction. We're then looking for inspection. Are there any gross leg length discrepancies or any deformities? Starting from the hips and the knees, is there any genu varus or genu valgus? Genu varus referring to sort of a bow-legged appearance, and genu valgus referring to knock-kneed. We then look at the foot and ankle, and looking at it from sort of the hind foot going forward. We're looking to see, is it in neutral alignment? Is it flat? Is it high arched? And then you look from the hind foot, midfoot, and forefoot. I'm going to switch over in this direction. So looking at Sammy's feet, her hind feet are in neutral. Her arch is well preserved. She has an intact longitudinal arch. She has some hallux valgus deformity. Hallux refers to the great toe. Valgus referring to a bunion, so turning outwards. And there is some pronation or some rotation to that toe, and that's classically seen with bunions. So again, looking at the hind foot, midfoot, and forefoot. Some abnormalities that you may want to look for, again, with flat feet, their hind foot would be in valgus. That would mean their heels are turning out. Their longitudinal arch would be on the ground, looking for the height of the navicular bone relative to the ground. The navicular bone being the bone in the middle of your arch where the posterior tib inserts. You're looking for any midfoot deformities, midfoot being in either adductus, meaning towards midline, or abductus, towards sort of laterally deviated. Again, the great toe bunion, if it's straight. And there is a condition called congenital hallux varus, or it can be from overcorrected bunion procedure where the great toe actually faces midline. That's hallux varus. With the lesser toes, that would be toes 2 through 5. The deformities that you'll classically see will be hammer toes, claw toes, and mallet toes, and that's what you'll want to take a look at. And you can refer to our online references as to how those appear. As Sammy has none of those structural deformities to point out today. So that would be observation. The second piece, again, with observation would be skin appearance. Are there any ulcers? Is there any redness? Is there any asymmetries of the skin? Any rashes, bumps, or lumps? Then vascular, in general, a well-perfused leg will be pink. You can look for any varicose veins or any sort of signs of arterial insufficiency, such as loss of hair growth in the toes, although you want to take note, sometimes females will shave their feet, so you'll want to ask them that question. But looking for any, you're looking for hair growth and seeing symmetrical hair growth, that's a sign of good arterial blood supply. That would be the majority of things I would look at in observation. Can you spin around to face the wall, Sammy? So part of the hind foot examination would be taking a look at the hind foot, the calcaneus bone relative to the long axis of the leg. And you can see that normal is about 5 degrees of hind foot valgus, and so that's pretty neutral. Very good, Sammy, and I'll have you pop on up. So we've covered gait, we've covered observation and alignment of the foot and ankle as well as the knee. The next portion that we'll dive into will be range of motion assessment. Range of motion is done either active or passive range of motion. If you're looking at examining the foot and ankle, which we are today, that would also include the hip and knee, but I'll let you reference those online videos, and we'll specifically just address foot and ankle. So the range of motion of the ankle, as you guys know, includes dorsiflexion, that would be the movement upwards, plantar flexion, which is the movement downwards, inversion, which means going towards midline, and then eversion is away. And Sammy has really good range of motion. Dorsiflexion normally is 20 degrees upwards, and we can use, spin on up here, Sammy. We can use a goniometer to measure passive range of motion or active. And we align it with the line of the tibia and along the 5th metatarsal border, and we'll dorsiflex her. And you want to see you get about 20 degrees of dorsiflexion. Plantar flexion is, she has a lot of plantar flexion. Normal is 40 degrees, and she certainly has a bit more than that. Go ahead and relax. Spin around for me again, Sam. We're now going to address inversion and eversion. Align the goniometer with the long axis of the 2nd metatarsal and along the long axis of the tibia. And then you stabilize sort of the central portion at the ankle joint. Inversion is typically about 30 degrees and eversion about 20 degrees if you're lining that up properly. And you always want to compare the contralateral side. And again, you can note active or passive range of motion depending on if the patient, what their pathology is. So that's range of motion assessment. Next, sensation. Sensation, you can look at it in different ways based on the nerves or based on the dermatomes. Dermatomes being L4, the medial border of the leg extending into the medial border of the foot. L5, which starts on the lateral border, extending into the dorsal part of the foot. And S1, which is along the posterior side, incorporates the bottom of the foot and the lateral side of the foot. And then there are the 5 nerves around the ankle. Those nerves can actually be traumatized, or they can be stretched, or they can be damaged in surgery or from trauma. And those 5 different nerves include the posterior tibial nerve, which supplies the plantar aspect of the foot. The saphenous nerve, which runs along with the greater saphenous vein, that supplies the medial border of the foot. The superficial peroneal nerve, which arises out of the fascia about 10 centimeters proximal to the tip of the lateral malleolus, and it extends along the dorsal medial and the dorsal lateral aspects of the foot. The deep peroneal nerve, which comes out and it supplies the first dorsal web space. And then lastly, the sural nerve, which is an extension of the short saphenous nerve, turns into the sural nerve in the foot, supplies the lateral border of the foot as well as the 4th and 5th toes. Sensation can be checked, as you know, with light touch sensation, sharp, dull, temperature. You can explore all those different options, but you just need to know what you're testing and what location. The dermatomes are different from the specific nerve innervation, so you're looking for overall gross pathology from the spinal cord level versus it being a localized nerve injury. And so just knowing where those nerves supply, you can correlate that with the patient's symptoms. Because we treat a lot of diabetics with foot and ankle, one of the other tests for sensation that you can use is called a 5.07 monofilament. And you can use that to test the plantar aspect. You can rest your leg on my leg. To test the bottom of the foot, generally I'll show the patient and say, this is a little monofilament. It's made of plastic. It's a standardized size. This does not hurt. Let me show you on your face. This is what it will feel like. And I ask them to close their eyes, and I ask them to identify the locations we're testing in the foot. I ask them to let me know when they feel it, and then to localize where they're feeling it, for example, what toe or what part of the foot. And typically you'll test about 10 points on the bottom of the foot, including the toes, the forefoot, the midfoot, and the hindfoot. And if the patients, and typically with diabetics, it's a stocking and glove distribution numbness, so they'll lose sensation at the tips and then it'll come into play where they can start to feel it up the leg. Whereas if they actually have like a nerve injury from a back surgery, they may feel it just specifically lost in one dermatome. So again, it's just helping you to figure out why they're having numbness. And so the monofilament we use this particularly to diagnose neuropathy and particularly in diabetics, but you'll also see it in patients with lupus that have neuropathy, alcoholics that have alcoholic neuropathy, B12 deficiency, etc. So the 5.07 monofilament is a good way to check to see if they have neuropathy, and that has implications with how we treat our patients. Going along the lines of completing our neurologic exam, a reflex exam is part of that. The patellar tendon reflex is your L4 reflex, and you hit the patellar tendon, and Sammy has an excellent reflex. Just be careful they don't kick you. And then the Achilles tendon reflex, go ahead and relax your leg there, Sam. We'll hit the back of the Achilles, and then they'll plantar flex. That's S1. So that's looking at 2 different reflexes, L4 and S1. You're looking to see if it's normal, if it's underactive, overactive, and so you can put that on a grading scale. And then also if they have any clonus, you can take the ankle and just look for any passive beating of the foot that could indicate an upper motor neuron lesion. So those are all things to take into consideration with reflex and tone. We'll then go on to specific testing of the foot and ankle. When I'm examining somebody, for example, trauma, one of the tests that you look for to see if they have a blood clot is called a Homan's test. A Homan's test is done while you squeeze the calf and see if that elicits any pain. You're also looking to, and that's pain in the calf area itself. You can dorsiflex the ankle and squeeze as well. You're looking for signs of swelling. Sometimes they don't have tremendous black and blue or any signs of external trauma. It can just be pain in the calf with some mild swelling. That would then prompt you to order a venous Doppler. So a Homan's test is looking for a deep vein thrombosis known as a DVT of the leg. Another test in the leg is the squeeze test. That's a test that's looking for integrity of the syndesmosis, which is a high ankle sprain injury that starts down here at the level of the ankle, extending upwards throughout the tib-fib region. We squeeze the top of the leg, and what we're looking to see is if that reproduces ankle pain. That could indicate a syndesmosis injury, certainly prompting x-rays of the tib-fib ankle and foot. The Thompson test, would you mind laying on your stomach, Sammy? The Thompson test is a test that we do to examine the Achilles tendon. Can you come towards me, Sammy? I'm not sure that we can actually videotape this quite closely, but the 4 signs of Achilles tendon rupture without even requiring an MRI would be looking for a palpable defect in this area. So you'd look to see, you'd feel along the Achilles, and then you'd feel your finger sort of fall into sort of an area where there's no Achilles, and that's called a palpable defect. And then it resumes as you attach. That would be a mid-substance tear. Sometimes they are also torn off the bone called the calcaneus. But it's, the normal Achilles tendon rupture is in the middle of the tendon, 2 to 6 centimeters up from its insertion, and you'd be looking for a palpable defect. You'd also be looking for excessive dorsiflexion, the inability of the patient to push. Go ahead and push into my foot, the inability to do that. And then the Thompson test, which is your classic test. Go ahead and relax your leg, Sam. So I would dorsiflex the foot, and we'd squeeze, and you'd see the foot would not go up, which Sammy is demonstrating because she's holding her leg down for me. But if she's actually relaxing, go ahead and relax your foot. See how that foot goes up when I squeeze the calf? So that's, that's a negative Thompson test. A positive one would be where the foot doesn't go up towards the ceiling when you squeeze the calf, indicating that something has been disrupted along the lines in the Achilles, typically a mid-substance Achilles tendon rupture, but it could be anywhere along that chain. We'll have you swing back to a seated position. Just as I'm sitting here reminding myself, one of the other pieces, swinging back to observation, is to always look at the patient's shoe wear. Now, Sammy actually has really good shoe wear here, but you're looking for any wear pattern in their shoes that can indicate the type of deformity that they have, or perhaps the type of abnormal gait pattern that can be influenced by the other joints of the leg, or if they have any neurologic conditions. So any particular wear pattern on their shoes, and again, looking for the presence of any braces or boots. Turning our attention back to the ankle, a lot of the physical exam of the foot and ankle is very basic, as we've described, range of motion, sensory, and then the specific tests. But some of it is just palpation and sort of figuring out where their pain is as to what the diagnosis is. So in general, if someone's had trauma, you're feeling through the different areas of the foot to see if there's any areas that, if they're tender, that could indicate in a child a growth plate injury, or in an adult a fracture or a sprain. So pain along the inside of the ankle, that's the medial malleolus. If it's tender there, that can indicate a fracture or a stress fracture. Pain along the posteromedial aspect of the ankle, that's usually tendinous. So that can be a flat foot deformity known as posterior tibialis tendinitis, and that's pain that extends into the arch. That's accompanied with findings of flat foot. Also, flexor digitorum longus and flexor hallucis longus are also tendons that you will palpate, and can be tender if there's inflammation or tenosynovitis in that area. Pain along the lateral side of the ankle, that's the peroneal tendons. Pain along the fibula, that could be a fibula fracture or a stress fracture. Pain between the fibula and the tibia, this is the high ankle sprain region, or the anterior tib-fib ligament. That'll be tender here. And again, that usually accompanies a positive squeeze test. So pain in the front of the ankle, that can indicate ankle arthritis or a fracture of the ankle. Moving downwards, palpating sort of each individual bone, the talus and navicular bones, the cuneiform bones, the metatarsals. If any area is particularly tender, even if x-rays are negative, be conscientious that there could be a stress fracture or something else going on if they're very tender. Specifically in the midfoot, everybody likes to talk about Lisfranc injury. So that's the connection between the second metatarsal base and the medial cuneiform. So it's a ligament that sort of connects the medial column to the lateral column. So you're looking for tenderness there. That's a Lisfranc injury. In the forefoot, pain in between the metatarsals, particularly the second web space and the third web space, you're looking for a pinched nerve called a Morton's neuroma. So palpable pain that when you squeeze, the toes go numb, the pain can radiate. So in the second web space, you're looking to see if the pain radiates into the second or third toes. Or if you're palpating the third web space, you can have numbness that radiates into the third and the fourth toes. One other classical test is the Mulder's Clunk test, where you basically you can do a squeeze test where you squeeze and see if that sort of compression medial lateral that can elicit that pain of a painful Morton's neuroma, or taking and compressing the two metatarsal heads, squeezing them together and then shucking them together, Mulder's Clunk test. You'll sometimes actually feel a clunk, and that should elicit pain and sometimes numbness, burning, or tingling into the toes. Always be wary for pain along the fifth metatarsal for pseudo-Jones or Jones fractures, pseudo-Jones being at the base, Jones fractures being at the metaphyseal-diaphyseal junction. That's one that you don't want to let the patient walk on and should see an orthopedic surgeon. One other part of the physical examination is assessment of range of motion of your great toe. Now you can see Sammy's had previous bunionectomy surgeries. She has a healed scar. So we're looking to see if she has any limited range of motion at the metatarsophalangeal joint, metatarsophalangeal joint, or the MTPJ. You're looking to see if that toe, and I'll show you without the goniometer, you're looking to see dorsiflexion and plantar flexion. And she has a little bit of range of motion loss, number one because of her bunion, number two because of her surgery. But normal is 90 degrees of upwards motion, and plantar flexion is typically about 20 degrees of plantar flexion. And again, any hammer toe, claw toe, or mallet toe deformities, hammer toes being extension of the metatarsophalangeal joint with flexion at the IP joint. Mallet toe is flexion of the DIP joint, and claw toes is flexion of the PIP and the DIP joint without that extension deformity at the metatarsophalangeal joint. And again, you can reference those deformities for examples on our online reference. So also on our palpation examination, if patients have pain at the medial calcaneal tubercle, that is an area that would indicate that they have plantar fasciitis, which is a ligament that connects the calcaneus or the heel bone to the metatarsal heads. It helps to hold up our arch when we walk. So you're looking for pain in that area. That's typically plantar fasciitis. If you have pain a little bit higher in this region, that's usually known as Baxter's nerve impingement. That can reproduce heel pain when you press in that area, or if you do what we call a Tinel's test, where you bang on the nerve and see if that reproduces heel pain into the bottom of the foot. That's a pinched nerve known as Baxter's nerve. Tarsal tunnel, which is a whole lot less common than carpal tunnel, refers to a pinched posterior tibial nerve that runs down the posterior medial aspect of the ankle, and the patient will complain of some numbness in the bottom of the foot. And again, you take your index and middle fingers and do a little percussion known as a Tinel's test. You percuss that nerve and you see if that reproduces pain, numbness, tingling, burning, electrical sensation into the bottom of the foot. One of the other considerations with plantar fasciitis is calcaneus stress fractures, or anyone who's perhaps fallen off a ladder or been involved in a car accident. If you take the sort of cup your hand and squeeze the back of their heel, if that's very tender, that can be indicative of a stress fracture of the calcaneus. That can be mistaken for plantar fasciitis, so you want to make sure you take a history if they've actually sustained trauma, a fall, a car accident, or if they're all of a sudden training for a half marathon and they've developed pain in their heel, or if they decided to go out and do the turkey trot and they haven't really been preparing. Patients can oftentimes get stress fractures in their heel, or stress fractures really in any bone of the foot. So you're looking for any location that's very tender. Typically a stress fracture, when you press on the bone, the patient will elicit a jump response, and that is fairly diagnostic for a stress fracture if it is over a bone, in my experience. Part of your physical examination will include an assessment of strength, and we will evaluate each of the tendons and grade them on a scale of 0 to 5, 5 being absolute paralysis, 1 being a twitch response, all the way up to 5 out of 5, which is full strength against resistance. 3 is against gravity, 4 is being able to apply resistance, but that you can break them through they can't hold full strength, you can break their resistance. So the first assessment of strength will be dorsiflexion. So go ahead and pull your toes up towards your nose. Sammy, hold that up towards the ceiling. Don't let me press you down. You're looking to see that predominantly her anterior tibialis tendon is intact, which you can actually see as she contracts, but also the extensors, so the extensor digitorum longus and extensor hallucis longus can contribute towards that. Then you're looking to see if the patient can plantar flex and invert. Go ahead and push inwards. That's checking posterior tib tendon. So go ahead and, Sammy, pull in towards midline and don't let me push you. And you're looking for the integrity of that tendon known as the posterior tib tendon that holds up the arch. It plantar flexes and inverts. Bring your foot out towards me and hold that. That's eversion. You're looking to assess peroneus longus and brevis, which are tendons that start on the lateral side of the fibula and tibia and insert on the base of the fifth metatarsal as well as the arch of the foot, and they help to evert, and you're looking to see how strong they are with eversion. Go ahead and push down again for me, Sammy. This is plantar flexion. Hold that down, and that's testing the Achilles tendon. And then specifically the toes. Sam, pull your big and little toes up towards the ceiling. Hold them up. Don't let me play the piano. I say don't let me play the piano, but that basically means don't let me push you down with my finger. And that would be hold your big toe up and hold your little guys up. You're looking to see that the extensor hallucis longus and the extensor digitorum longus, as well as the respective extensor hallucis brevis, extensor digitorum brevis, that those tendons are intact. One other special test that we will do on the patients when they're standing. Sammy, can you please stand on your right leg? Can you go up on your tippy toes? So when evaluating a patient, you can relax. That assesses a whole lot of things, balance and coordination and Achilles tendon strength and all those things. But we're really looking at the posterior tib tendon and specifically flat foot deformity. You're looking to see if they have a flat foot, if it's a flexible flat foot, and if they're able to go up on their toes. So if the foot is flat and they go up on their tippy toes, that means that tendon is still intact and it's a flexible deformity. If you see they can't go up on their toes, that usually means that the posterior tibialis tendon is torn, and also sometimes there's other reasons, but that's really what we're looking at is evaluating flexibility of the flat foot and the integrity of the posterior tibialis tendon. Part of your assessment of gait and neuromuscular control should also include toe and heel walking. Sammy, can you walk on your toes towards me? So you're assessing her S1 nerve function, and you're also assessing her sense of balance. And then Sam, can you go down, just relax, now walk on your heels towards me. And again, this is the L4 nerve that we're checking, anterior tib tendon function, and again, balance and coordination. Sam, can you come to the center of the room? I'll just have you face this direction. A lot of the patients that get sent to us have sustained ankle sprains or an inversion injury to the ankle. Part of the assessment of proprioception is checking to see their single leg stance, if they have good balance. Sammy, can you stand on your left leg? Put your arms open wide like a T. So you're looking to see, can the patient maintain, and try not to touch your right leg next to your left leg. That's sort of known as cheating. We want to keep those apart. You're not cheating, it's just part of the exam. Cross your arms. So as we close the sort of base of support, it becomes more challenging, and then close your eyes. Remember that a good percentage of balance that comes from your eyes and your vision, 70% I believe comes from vision. So we're checking her proprioception of her ankle as well as her inner ear, her vestibular system with this. Go ahead and open your eyes now and relax. So as you close down the base of support and then close the eyes, you're really checking proprioception of the ankle and also take into consideration if they have any vestibular disorders that they may have trouble doing this. But particularly for foot and ankle, we're looking to see if they've gotten balance back after spraining a ligament, the anterior talofibular ligament in particular. One of the points to bring up is always checking the contralateral side. Sammy, can you stand on your right leg? Arms open. And you're looking really to see if there's any asymmetry with her foot strategy, if she's pronating more, supinating more, if she can maintain it for the same amount of time. I usually use 30 seconds as a guide. Cross your arms. You can see she's working a bit harder on this leg, and close your eyes. You can see that the strategy is a little bit more difficult. This could indicate that Sammy's had a ligament injury. She may have some arthritis in the ankle. There may be a whole lot of reasons. But if it's not a painful ankle, usually we're just checking to see if their sense of proprioception is there. And if there's asymmetry, that indicates that perhaps physical therapy is necessary in functional retraining of the ankle. Part of our palpation exam includes evaluation of Morton's neuromas, which typically are the second web space, which is between the second and third metatarsal, and also third web space, which is between the third and the fourth metatarsal. The patient will commonly complain of a feeling of a balled up sock, numbness, burning, and tingling that can extend into the toes. So for the second web space, you're looking for pain that would be between the two metatarsal heads, second and third, and you're looking to press, hold, and see and ask the patient, is it radiating numbness, burning, and tingling into the toes? Similarly, in the third web space, that would be for the third and fourth toe, because those are the digital nerves those nerves supply. Part of the physical exam would include squeezing, sort of compression between the medial lateral surfaces. That can reproduce pain, sometimes even a popping sensation in the foot. And then the Mulder's clunk test, where you actually will gently grip the foot and compress the two metatarsal heads together and then shuck them up and down like piano keys, and you're looking to reproduce a clunk, and or the patient's symptoms are looking to reproduce their pain, numbness, burning, tingling, whatever the sensation of nerve pain they have that radiates into the toes, or at least localized pain to that area. Part of the physical examination includes assessing ankle stability and ligament stability. So the anterior drawer test is done with the foot in plantar flexion, a position of comfort, gripping the back of the calcaneus, stabilizing the tibia, and translating the talus forward on the tibia and looking for any instability. And you can compare that to the contralateral side, where you again stabilize it and compare the amount of translation forward. And that can be graded on a very simple grading scale, as if it's symmetrical to the other side, or if it's loose or if it's tight, but there is a grading scale of 1 through 3. And then calcaneal tilt test, you bring the ankle to neutral dorsiflexion, and you're looking to see the amount of inversion. And so you're cupping the calcaneus with your hand, stabilizing the foot at neutral, and how much inversion the patient's hind foot achieves. And that is checking the calcaneofibular ligament, whereas the anterior drawer is assessing the anterior talofibular ligament, as you can see here. And again, you compare that to the contralateral side. And you're looking for asymmetry, hypermobility, or hypomobility. Again, typically done in the situation of an ankle sprain. And if the patient is acutely injured, oftentimes they guard, and this test can sometimes underrepresent the amount of instability if they're guarding. Well, I've enjoyed presenting to you the foot and ankle section of our physical exam, and I wish you guys good luck in studying and with your careers. Thank you.